Hi, my name is Richard Isaacson. I'm director of the Alzheimer's Prevention Clinic at Weill Cornell Medicine and New York Presbyterian. Today, we're going to be talking about endpoints in Alzheimer's disease clinical trials. Let's now discuss the MiniMental State Examination, or the MMSE. The Folstein MMSE has been around for many decades, and it's a performance outcome that quantitatively assesses the severity of cognitive impairment. It's something that has been used literally for decades by physicians and researchers kind of throughout the world. And it has a lot of benefits because we all have a sense of what a 30 means, what a 25 means, what a 20, what a 15 out of a 30-point scale means. That being said, it's not precise. It's not perfect. It's a good screening test, but it's definitely not a good diagnostic test in terms of making a definitive diagnosis of a specific neurological condition like a certain dementia. In terms of section 1 has 21 of the 30 points, and that covers orientation, memory, and attention. And these are cognitive domains that are critical in terms of understanding a person's trajectory of Alzheimer's disease pathology or pathological cognitive decline related to Alzheimer's itself. And then section 2 tests the ability to name, to follow verbal and written commands, as well as write a sentence spontaneously. In addition, they also have to, patients have to copy a figure, and that's complex processing and visual spatial skills, and that's 9 points in section 2, again, for a total of 30 points. The lower the score indicates increasing cognitive impairment. If someone has a score of, say, 23 or 24, that's indicative of cognitive impairment or dementia. Although this is tricky because, for example, a person that has very, very high educational attainment, they may be scoring a 27, 28, or 29, and that person may have a reasonable degree of impairment, or at least be in the MCI stages, but that person may score on the high end of the test, but still have deficits that are apparent both clinically as well as in terms of objective clinical testing. When it comes to thresholds for clinically meaningful decline, this is tricky because it's, sometimes the scale doesn't move exactly as predicted over time, especially as a person is at different stages of the disease. It's harder to say, okay, great, well, you improved or you stabilized by 1 point. What does that mean? Well, it means different things depending on where the person is in the clinical spectrum. When it comes to insights from clinical practice, the advantages are it's very well known. People, again, are fluent in terms of understanding what a 30 means versus a 25 versus a 20 or lower. It's quick to use, takes 7 to 8 minutes or so on average, anywhere between 5 and 10 minutes, I think, depending on the person, depending on their severity of cognitive decline. It's commonly used in clinical practice, and it's considered in some ways more accurate for classifying the more moderate stages of dementia. In terms of the limitations, well, there's a potential impact from education, from sociocultural values as variables, as well as age. It's less sensitive to subtle changes over time, especially in people with mild cognitive impairment, and especially those with MCI with high educational attainment. These cutoff points can vary quite a bit in terms of what one person's 21 out of 30 means versus another 21 out of 30 versus another. Someone may get a 28, and that may be completely normal. And other people, very well-educated people, that 28 may be, easily in the MCI range. The other aspect of the MMSE that's a limitation is the outcome of the test score doesn't always relate to how the outcome is doing in terms of the clinical setting. There's also not assessments of executive function, higher order processing skills. And over the last several years, the use of the MMSE has gone down quite a bit because of licensing and copyright requirements that clinicians need to think about when administering in their practice.